Okay, I think I see the numbers are no longer growing in terms of people coming in. So I think we can start. Again, as I said, my name is Lungelo. I'll be co-hosting for today. Thank you very much for making time to actually join us on this virtual presentation. I would like to introduce Bruno, who's going to be taking us through on the pain management presentation for today. Bruno has got managerial experience in various industries, which is France-based. Bruno has joined Micrel, which is the company that is representing medical devices in 2009. He is tasked with bringing the gap between suppliers and healthcare organizations to distribute ambulatory infusion solutions. Bruno has gained invaluable experience and expertise in various therapeutics, including pain management system, which is post-op, obstetric, and cancer pain. He's also got a parental nutrition and home chemotherapies, including immune globulin. Yeah, there's a terminology for you. Infusions and primary pulmonary hypertension treatments. So we can appreciate that the knowledge and the information is going to be shared with us is going to be beneficial, but I'm not going to waste too much time. I'm going to hand over to Bruno to take us through. Hi, Bruno. I would like to introduce you to our team members, Kiza, and yeah, they are looking forward to hear from you.
Lungelo, thank you. Thank you very much. Thank you for the team in South Africa, our partner, Business Cabby, to invite you to that presentation. You confirm that the sound is good, Lungelo? Still good? Yeah?
100%. Sound is good.
Okay, thank you. I will launch the presentation soon. So yeah, correct. I'm operating for 15 years now, 15. The infusion therapies could be at home or in hospitals. So the purpose is to discuss, to share our expertise, what we have met about pain management in hospitals. Just introduction. So just to explain that you are a bit southern for us. Alwyn is still in Dubai. You hear him. Thank you, Alwyn. Our head office in Athens. I am French-based, and I apologize in advance for my French accent. I try to speak slowly and clearly. We will still be a bit more in Europe because I will share with you pain management protocols from a teaching hospital in Switzerland, but which is very close to what I met in South Africa, because the practice could be almost the same when we talk about pain management. So the topic is how to respond to pain treatment with the appropriate solutions. The purpose of the day is to share with you what are the constraints of pain management, because you are useful about infusion devices. You are taking care, maintaining all, let's say, day long in the hospital, but sometimes you don't have the full pictures about what are the clinical needs it is answering. So we'll explain shortly how to optimize pain management, okay? And what could be the best combination for these specific needs. Then how could we choose the best solution for the patient, and not only for the patient, we'll see that. And about pain management, what could be the real innovation that could help to improve the practice, some Q&A, and it will be time to wrap up. So let's try to optimize the time you spend with us. I'm launching my clock. So in pain management, the question is, okay, what are the common points from a patient having a surgery and parturian coming from delivery? But the answer is obvious. It is acute pain, because both are very painful. And if we think about post-operative patients, 39% are still reporting severe pain after surgery, even when they are receiving analgesia. And we know at the same time that pain relief and mobility are linked together. and they are the two key factors to perform a good surgical recovery. In case the pain management is not performed properly, it could lead to first of all, poor patient satisfaction, because we know that the pain management is a big part of the pain perceived is a big part of the patient satisfaction. It is delaying the recovery, because when you have pain, you cannot perform your physiotherapy. Okay, that means that you will stay longer in the hospital. It will for sure increase the hospital expenses, because if your organization is receiving a forfeit of 2 days and the patient is staying 3, 4, 5 days because he has pain, it will cost money. Aside, the patient will try to compensate the pain by having opioids. And we know that in the US, opioids consumptions, it's a big national health issue because you have a chronic pain syndrome and addictions of big part of the population. In some cases, it is leading to hospital readmission. So when you talk about pain management, it's not only a question of comfort for the patients, okay? It has a huge impact on all the healthcare system. And same for birth delivery. We know that women who have a continuous epidural infusion, which looks good because they don't have pain, when it is leading to motor blockage, that means that in 20% of the case, women may have a delivery, and the obstetrician will use the tool to deliver the baby. So it's far to be appropriate definitively. Almost 30% of the C-section could be reduced by the change of the position. That means if the partorian could move and walk, it could change really the outcome of the delivery. Okay, and in total, still 14% of the women are experiencing breakthrough pain during labor. So definitively, we can do more. Let's say that we have to do better. So when we go for pain management, you have some protocols. The practice all over the world for advanced practice is almost the same. Okay, here I'm showing, that's why it's a bit in French, but it will be easy to understand. Protocol from a teaching hospital, HUG in Geneva. Okay, you see that the drug they are pushing for pain management it's not marginal. Here we're talking about morphine. Okay, you can see that the units to infuse that drugs could change. If it is morphine, it could be in milligrams. If it is fentanyl, it could be in microgram. But if you go on local anesthetic drugs, it could be in milliliters, because it is already compounded. So the programming, the infusion itself, let's say that for pain management, pushing a basal rate is not enough. Which is making the success of a pain management is a basal rate, but it is a match with bolus, meaning a dose that the patient will ask by himself. It is matched with a local period, meaning a period in between the patient cannot ask a bolus to avoid overdosage. And sometimes you may have, as it is mentioned here, on the duration of 4 hours, a limitation of the total amount of drug that the patient will receive. So, being said, pain management is a bit complex in terms of infusion mode and infusion profile. And you see also the volume. Here we talk about 100, 200, or could be more for a pre-filled bag. That means that it's far above the volume of a simple syringe. What are the criteria which are pushing to improve or to optimize the pain management? The first one, the safety. We just saw on the former slides that when you are infusing morphine, we can all easily understand that the drug bag has to be protected. No reason, no way to have it as open bar access, okay? The programming has to be secure, because if we go by mistake to another infusion, it could be lethal for the patient, it's obvious. And we can understand that in that condition, we need an accurate infusion. We have seen the low volume to be infused per hour. So accuracy is obvious, it's a must. The second point, after safety, it's a patient mobilization. we've seen in the introduction. The patient, you keep a patient lay down. Base case, the patient is not recovering. If it is about elderly people, it is leading the patient to the death. Okay, so the patients have to leave their bed. It's mandatory, not to run around the building of the hospital, obviously, but to have the capability. To leave the bed, to go to the bathroom, to go to the armchair, to have a walk in the corridor. And this first step are essential because this is the first step for the recovery. Next stage after safety and patient mobilization is what we call patient-centered treatment. Why? Because the pain management you may receive for knee surgery, for hip replacement, for thoracic surgery or abdominal surgery, or even more for birth delivery, they will not be the same. The drug is not exactly the same molecule. It could be epidural, it could be local regional analgesia, it could be IV. Okay, so depending on the surgery and the choice of the anesthetist, infusion mode will be different. Also, which is crucial from pain management, is historical. What we call historical is a ratio between bolus demand from the patient and the bolus he has received. Okay, you remember that we have some lookout period. Okay, that means that more the patient, if the patient is asking more bolus than the programming of the device is allowing, that means the patient has pain. Okay, so this is the main criteria to understand the statement of the patient. Thus, we can deduce pain trajectory, meaning that after the surgery, is the patient going better and better, or is the situation stable, or has the patient still a high level of pain? Obviously, this information will lead to adjustment of the protocol by the doctor and the pain team. So safety, patient mobilization, and patient-centered treatment are the three key to optimize the pain management and to avoid the pain point we have seen formerly. So longer recovery and maybe re-hospitalizations. Currently, what are the different options to operate? Obviously, gravity. You have plenty of fluid infused by gravity in the hospital still. Let's see if it is appropriate or not. The second solution could be elastomeric pump, okay, what's called a balloon pump. So we infuse the fluid inside the balloon, and the pressure of the membrane is pushing the fluid back into the patient. This is the second option. The third option is the PCA ambulatory pump, okay, so small portable pump. We'll explain that later on. And the fourth one, the syringe drivers. Again, you have tons of syringe driver in your hospital. A big part of the fluid of the drugs received by the patients are infused through syringe drivers. But the question, does it appropriate for pain management purpose? So the idea here is, I think I have a mismatch on my presentation, sorry. What is the most appropriate tool for each clinician needs? As my colleague who is an engineer told me, he said, yeah, I'm surprised that you are using a hammer to fix a screw. I said, yeah, well done. This is exactly the purpose of the slide. Sometimes if you don't have the appropriate tool, you cannot operate properly. So here, the idea is just to match the infusion solution we do have on one side, so gravity, elastomeric syringe drivers, and ambulatory PCA pump, and the criteria, the needs to optimize the pain management, so which are safety, patient mobilization, and patient-centered treatment. If we go through one after the other, okay, we can observe that for gravity, in terms of safety, it doesn't fit at all because you have the bag hang, okay? You don't have accuracy. And in case of adverse event, the team is not warm. So if it turns bad, nobody knows. In terms of mobilization, no, it's not portable. And it's not dedicated, you have only basal rates, no history, etc. So let's say that the gravity infusion is poorly fitting pain management. So the second solution could be elastomic pump, which is quite used a lot in your. I have a slide that disappeared in the wrong place. Sorry. Elastomic pumps are still largely used. It's a good solution, but in terms of safety, yes, the drug is protected inside the container, so it's fine. Where I start to be a bit more tricky, it's about infusion accuracy, and we can develop, because in terms of infusion accuracy, I have a flyer on my screen. The performance of such a solution is impacted by the temperature. You see, it could be plus minus 2.3% anytime you have a change of 1 degree Celsius, okay, of the temperature. The positioning, if you have the pump 2.5 centimeters below or upper, it could change 0.5%, etc. The viscosity is impacting if they are using sodium chloride. Okay, it could infuse 10% faster. The size of the needle is important, and also the label volume, meaning that if you don't 100% fill your balloon pump, you may have an over infusion. So for this reason, in terms of infusion accuracy, remember the infusion rate required for pain management is not fitting at all. Furthermore, in terms of alarms, if you have occlusion, nobody will know, the patient will not receive the dose. Portability is fine, very fine. Autonomy is fine. This is the success of this solution. But when you start to think about the optimization of the pain management, let's say that it is a disaster because you have only basal rate, barely bolus, okay, no tuning, you don't have information about its infusion history or bolus ratio, and forget the pain trajectory. So let's say that if you are rating elastomeric, maximum 3 points could be collected. Next options could be syringe drivers. If in terms of accuracy, it's definitely the best solution. Okay, we know that that device is very accurate. They are very good for, let's say, very critical infusions and drugs, such we do have in intensive care units. But the syringe is not protected in many cases. In terms of patient mobilization, neither is not fantastic. It is considered as a fixed devices. So it's not because we put wheels under the IV pole that it will really help the patient to be immobilized. We know that for elderly people, sometimes they try to grab the IV pole and they are falling after the surgery because they don't have the two hands to grab something. And in terms of dedication to pain management, sometimes it could be limited for organic infusion mode, and I'm especially thinking about program intermittent bolus for obstetric, and now more and more required for post-op pain management. The next solution offered to us would be the PCA pump. So here the drug container is protected. You have the infusion accuracy that you would have with the static syringe drivers. In case of occlusion, end of infusion, etc., the pump will alarm, so the nursing team will be prevented. You have the portability that the syringe driver is not bringing. And in terms of patient-centered care, you have specific infusion mode for PCA and PCA and PIB. You have very easily on a glance, you press a button, you have the information regarding a bolus infused versus bolus demand, and you have some graph on the pump regarding potential pain trajectory to understand if the pain is stable, increasing or decreasing. So if we choose the best option, definitively for pain management, and I really focus here on pain management, okay, an ambulatory PCA or PCEA for if is for epidural here, infusion pump is probably the best solution. Okay, so if we go in details, in terms of safety, you can see on the drawing here that the container of the drug is integrated inside the device, so it is protected. You see the pumping mechanism here. These pumps are features with peristaltic mechanism. So in terms of accuracy, we are not as well accurate such syringe driver, but nearby here it's plus minus 5, it is announced. but in reality, at low rate, it's close to 2%. And in case of abnormal condition, the pump will alarm if there is an occlusion. The pump will prevent when it's near end of infusion, or in case of low battery. So for safety, the system is doing the job. If we think about the treatment itself, indeed that pump are designed for pain management, because in the programming menu, you will have all the type of infusion mode required. Could be continuous, could be bolus, continuous plus bolus, bolus only, program epidural, intermittent bolus. So all the type of programming are there. They have access to infusion history and bolus ratio, and even so to the graph on the screen, whatever the size of the screen. In terms of patient mobilization here, in that case, we are around 300 grams, including the battery, and it is provided an autonomy of more than 5 days in the post-op protocol, meaning continuous plus bolus. Here, the data are continuous plus bolus every 20 minutes. So perfect solution. The drug is protected, the infusion is safe in case of you have alarms. The nursing team can program the pump with the appropriate programming, okay? They can have a look bedside to see if the patient has pain, and if the patient, and to mobilize the patient have the pump in a carrying bag, and they can move freely, having the two hands to grab and to secure the first path. What it does provide also, it's in terms of staff efficiency, because we used to focus on patients, but we need to focus more and more on the staff taking care of the patients, because all over the planet we have a shortage in terms of nursing, and less budget to take care of our patients. So staff efficiency start to be a real major things we have to consider in the choice of a solution or a device. Here you have the easiness of the system, because all is included. You have the reservoir, you have the line. You can even program the pump through a pre-programmed protocol. You program the protocol on the computer, and you download them into the pump, so it makes the program very free and easy. Now the devices are equipped with features to reduce the alarm nuisance. Here, there are some airline eliminator filter, meaning that the patient is protected against air embolism, but this is a filter will do the job, and the pump is not alarming. So if there are air bubbles, it will pass through the filter. The patient is protected, but the pump is not alarming. So there are even more time saved by the team and interventions. Same for automatic restart after occlusion release or long-lasting battery. So in terms of nursing intervention, this system, I believe, at the top of the practice, and help to reduce unnecessary nurse visits. And you have also the patient feedback. Now it's possible to record the pain score. The patient they can record the level of pain from 0 to 10, the level of pain, and then when the doctor is visiting, they know what is the statement in terms of pain. So that point are making, so that's finally ambulatory PCA or PCA infusion pump are definitively the best option for pain management, and because they are dedicated for pain management upon the need. The next questions would be, what about innovations? What's the main innovations? Let's say passing through all the category of devices and let's say penetrating all the practices, it's about connectivity. In that case, what connectivity would mean? Here, the purpose is just to connect a small device, which is a mobile with a SIM card in it, okay, to the pump. Then the device will send the information to a web platform, okay, and will store where the data are hosted, and on demand, the clinical team will log on the account and will have access to the information of the infusion. This is the next stage. So the question, what does it provide? Okay, the first things, it is in terms of improvement, it will be safety. Okay, why? Because anytime it will be possible to have a look about the programming of the pump. We know that sometimes due to the turnover and the lack of training, some nurses could be led to program a PCA pump without having the knowledge, or operating under stress, operating late in the night. It could lead to a programming mistake. And here, from a distance, the pain team could have a look and confirm if the programming was appropriate regarding the prescriptions. Also, in terms of infusion history, in some practice, the nurse, they have to pick up information. It's very complicated because you need to take the pump, you need to download the historical on the computer. Sometimes the pump come back to you in your workshop or to your team, and it's not an easy task. Here, on a glance, you click and you have all the historical of the infusion. So to improve safety, it's a great point, because from distance you know exactly what was the programming of the pump. The second point is about staff workflow and efficiency. The first thing will be in case of alarms. Someone call, they said, hey, your pump of your patient, Mr. John Miles, is alarming. The team can click, have a look, and can identify the alarm, and potentially from distance explain to the nurse, okay, take it easy. You have an occlusion in the line. Just check if the line is not blocking the bed, and it will restart by itself. Okay, if it doesn't start, it's more serious, then we will come. So whatever at home or even in hospital, it will help a lot the pain team to manage the patients who are spread all over the hospital. The second big point, it's about volume tracking, because we know that during after the surgery, the demand patient to patient will be different, and maybe a patient is asking a lot and will not have enough drug in the bag for the duration of the whole night. So it's mandatory, if we don't want that the night shift has to change the bag. And sometimes they don't change. They switch the pump off and they disconnect the patient, which is the worst. Okay. So here, the purpose is potentially to anticipate what is here. If the drug bag will be too close to be empty, and to anticipate that. So alarms, bag infusion volume, ease of documenting. It works for safety, but in some practice, they have to check daily and to report all the infusion parameters, but also in terms of fleet management. So it's a bit more in terms of a technical point of view. The system allows you not to locate exactly where is the pump, but to know which patient the pump has been assigned. So it will be very convenient when you are looking for a pump. You dial the number on the screen, and you know immediately which patient, which ward has been assigned. Also, it provides information about maintenance, which is not marginal, even if you have already your own system to pilot that. Next step. So we talk about safety. We talk about workflow. The next step is just the focus in terms of pain management itself. Okay. We told before that to optimize, or to understand or to analyze the level of pain of the patient, the team is checking the ratio between the bolus demanded by the patient and what the programs, what the pump has finally infused. Okay, so this bolus ratio is super important. So the nurse are supposed every morning to check on the pump this bolus ratio. But what happens often is that they forget, they don't have time, or the counter has not been erased. So maybe the values, data they're reporting are not the data of the last night, but the data of the last day, of the last 2 days. Okay, meaning that the picture which will be reported in terms of pain to analyze to diagnose the pain of the patient is wrong. Here, which is fantastic, is on a click, you know, you can choose the window for the last 8, 4, 8, 12, or 24 hours, and you can see if the ratio is fitting to the reality, and then you can provide the appropriate response in terms of pain management. The next step, So then this point allows to the team, or here it's 0, okay, we are fine, to know if the patient has pain or not. But what they don't know is when the patient has pain. Why? So important, because depending if the patient has pain during the night, so it's more inflammatory. If the patient has pain during mobilization or at the end of the day, okay, which could be stress, then the clinical response should not be the same, because you don't load in opioids in case of you have inflammation. You don't load if it is stress because the night is coming. So here again, such an innovation is providing a decision-making tool that was not available before. So they know exactly when the patient has pain, and they can provide the appropriate response to drop the pain, to provide the appropriate pain management, and to help the patient having a faster recovery and to be discharged, to leave the hospital in the schedule planned by the forfeit or by the care plan. And that's it. So I just checked, maybe I was a bit faster than scheduled on the presentation. I hope I was not too fast. Nevertheless, you can take the lead again, and we can go for a couple of questions if I was too fast, or if you wish to have further information or what we have developed so far.
Thanks, Bruno, for that very insight presentation. I always say we as engineers, we sometimes don't get to be exposed on the clinical side of equipment that we're dealing with. So to actually get that insight also and to marry the two is very crucial to understand our clinician, if ever there is any fault that is reported to us, and to understand also the application of the equipment itself. So really appreciate that insight. Just maybe one or two questions on our side. On the presentation of your pain management or optimization of pain management, I see you mentioned PEIB.
Yeah.
On the slide. If maybe you can just assist on what does it mean, and also, if so, why is it important for obstetric?
Yes, thank you for the questions. Yeah, first of all, Longelo, yeah, I think this is our duty to be able, because we know you have I don't know the quantity of devices you have to take care, even infusion devices, and I think it's important what is the needs behind. And for PIB, so PIB means program epidural intermittent bolus. I don't have further, I don't know if you see me, I don't have a slide again too, but I just share the information. PIB, so to make the long story short, so far, when you think about epidural infusion, you have a basal rate, okay, let's say 5 ml per hour. And when the patient has pain, she presses the button and she's receiving a bolus. They have observed that for birth deliveries, these patients are not suffering of pain, but they could face motor blockage. And when you are in the labor phase and you have motor blockage, that means that you cannot push on your legs. That means you will not be able to deliver your baby by yourself. So then it's mandatory to have the obstetricians to pull the baby out with obstetrical tools. Okay, so it could be hurting for the baby, it could be hurting for the parturients. So it's far to be the best solution for delivery. And what some doctors have observed is that first they were looking for what is the root of this motor blockage, and they have observed that the basal rate provided during the pain management was leading to motor blockage. It is, I don't go too much into details, but it is leading to a gradient, a non-gradient between the external and the internal, the inside of the nerve, making that the nerve doesn't work. So it doesn't stop the message, it blocks the nerve totally. It is leading to motor blockage. So they said, wow, how could we do to keep a good pain relief and avoiding the motor blockage? And this is where the use of the appropriate infusion mode is important, is that they realize that instead of having 5 ml of basal rate plus the bolus, if you keep the bolus, obviously, when the patient has pain, but the 5 ml in continuous, okay, so 5 ml each is 5 ml in 1 hour. You keep this 5 ml and you infuse this 5 ml in one automatic bolus every 60 minutes, which is apparently the best practice. And they realize that you increase the quality of the pain relief and you avoid the motor blockage. They discovered, and now it starts to be the gold practice, that with the same drugs, you can largely improve the quality of the pain management just by changing the infusion mode. But for that, you need to have the appropriate device allowing to program the pump to infuse by that way. So nowadays, PIB worldwide start to be a must, okay? And it seems to be so performing that you have some doctor who start to use it in post-operative pain management when they need to go for spinal pain management, meaning that it's not epidural to have a block of the hips, but you go a bit higher in the colon to perform a pain management in a different part of the body. It could be thoracic, abdominal, etc. I don't know, Angelo, if I was clear enough.
No, 100%. No, quite clear. No, thanks for that. And tell me, with regards to the pumps or your platform, is it open to what? Maybe some of the pumps available in the market, or is it only unique for a specific pumps? And maybe if so, how is it connected? Is it possible to connect it to hospital information system?
Very smart question. Maybe I don't know if I have the end to potentially come back to the little drawing. Maybe it will help to support my my explanation and my French accents. I don't know, Angelo, if I can have access again.
We'll search in the meantime. But would you say it's actually open to?
Yeah, sorry. Okay. This platform is dedicated to in our case to micro ambulatory infusion devices. Okay. And it is let's say that it is captive. So only micro device is sending information on the platform called MicroCare. Which is very convenient in that it's not an app, it is web-based. Okay, so wherever is the clinical team, if you have a web access, you can log on with your code and you have access to the infusion status of your patients. It is protected. The platform is hosted in a specific hosting company dedicated to health data. They are protected and they're working under the ISO 27000 or 27001. But now to answer to your question, it is strictly limited to micro medical devices. Regarding the next question you said about interoperability, indeed it will be the bridge, meaning the pump is sending information to the platform. Okay. And this platform has been designed to be able to communicate in a language you know very well, which is HL7, and able to provide to answer to protocols in terms of infusion data and in terms of infusion alarms or alarms during infusion. So it will be the next step. To be frank, this development is still in progress. We are chasing an hospital in Europe currently to have this first cooperation with the IT team. But let's say that between 12 to 24 months, microhealthcare will be able to send directly the information inside your hospital information system. If it is an open system, meaning is if your integrator is open for that. I'm missing what I was saying, but yeah, globally here we are. So it's not available yet, but it is. It has been scheduled. It is in. The development is in progress. Yeah. What I want to say also is that the screen I shown you, whatever microhealthcare will send information on your hospital information system, the graph, all the information to pilot the pathway for the patient will be still needed. Okay, sharing this information will remain a key to provide the best pain management possible.
Okay, no, that's super. No, thanks for that, Bruno. And where would you say the data is hosted? Sorry, you've got the rights to manipulate the presentation on your side, but it's fine.
No, it's okay.
Yeah, for the benefit of our colleagues, we will share the presentation later on our platforms for anyone to access. So yeah, the data, where would you say is hosted, Bruno?
I'd say it's a big question. Indeed, the data are hosted currently in Europe, in France, in a company called Claranet. They are a big company. They are approved and dedicated for that. So don't worry. I'm not at the origin of the choice of that company. But initially, Michael did the choice of a company in France because 7 years ago, it was the most restrictive and the most protective regulation for health data hosting. Okay. Now the European Council took this, let's say, this frame in terms of regulations. The big advantage is that, so I know that sometimes it could be a bit disturbing because that means that the data of your patient are not hosted in your country. But the big question is not where it is hosted. The question is how it is hosted, meaning that the big advantage is that we are not obliged to open a bridge in the fortress of your server, okay, because it is hosted apart. Because we have to consider that what are the data. Of course, we talk about health data, okay, because you have information about the patients. You have his age, okay. You have the number, the molecule infused. You have the number of bolus received, etc. But that's it. And the big advantage is that it could be operated aside your own system, okay, in very protected and secure conditions. So for your information, we have microcare patients in UK, and UK is not part of Europe anymore. So we have patients in Germany, in Switzerland, for the main, in France, obviously now. So, but indeed, even for UK, and you can understand that they could be very protective in the way to proceed, or including their health data, and they have approved that that solution, having the data hosted in that company in Paris.
Okay. No, that's interesting. No, thanks, Bruno, for that. I'm looking at.
Very welcome. Just so long, sorry to apologize to finish on that. I know that because sometimes this is the first when we talk with your colleagues from IT. It is perceived as a weakness because we cannot be hosted and integrated, but hosting data and maintaining such a platform is very expensive also for the hospital. So it helps to reduce the cost. The sole question is what about the data protection? And on that point, yeah, we comply and we can explain easily how it as well.
Okay. That's interesting. That's interesting. Yeah, I'm looking at the chat box. I see there's a question here from Jürgen. It says, Bruno, what is the service interval on the device?
3 years. It's part of usually in all medical device or in many devices you may have in a workshop. Your team has to interfere every year. In Micrel, we made something a bit different. It's every 3 years only. Yeah.
Okay. So, okay.
For this specific device, let's say that it's when we have to prove that we are reliable. This is the answer we provide. Okay, you will have to go for maintenance only every 3 years.
Okay. No, that's fine. Yeah, thanks, Bruno. I see, yeah, in the chat box, it doesn't look like we've got another question. But for the benefit of everyone attending, I would like to maybe thank Bruno for also being kind to us to offer his presentation to be posted on our social medias, Kiza. So if maybe there is anything later on that comes to mind that you would like to maybe quick reference to what was presented today, feel free to log in and just to check the content. But yeah, on our side, yeah, that's it. And a special thank you to you, Bruno.
Thanks to you.
for
Thanks
time.
to you. I'm very pleased. I'm very pleased, and it's always a nice window. It's an opportunity that we cannot miss. So we have to thank our partner in South Africa, Fresenius Kabi, and I know that it is led by Jürgen himself. Thank you for the window inside your organization, because, and we hope that it was helpful in a way. So the purpose is not to say what is wrong, what is good, what is bad, but just to say, okay, depending on what you have to perform, please take care to provide for your clinical team the appropriate solution, because the impact in terms of patient care and patient outcome could be a great change. So thank you for that window, and all the best to the attendees.
No problem. No, thanks. And for our local colleagues, feel free to interact with the Fresenius Kabi colleagues if ever also you want more information over and above the presentation that will be available on our website. So yeah, I think that brings us to the end of our presentation today. And for any more presentation or webinars, please also log into our website, and you will be informed on what will be next for us to share. Thank you for attending.